Hello, everyone. Welcome to the Asia Ventilation podcast. This is a tips and tricks series. And today, we are really happy to have Professor Marcelo Amato, who is a professor in the Faculty of Medicine at the University of Sāo Paulo in Brazil. And he is also a pulmonologist and intensivist at the Pulmonary Division of the Hospital das Clínicas. And he's a guru in mechanical ventilation, and we all know about all the high-impact research that he has published. So my name is Jason Phua, and Prof, welcome.
Thank you very much, Jason. It's a pleasure to be here.
Thanks, Prof. So I think today we're going to talk about how you use driving pressure, but maybe just starting with the basics. We know that when we talk about ventilator-associated or induced lung injury, we talk about volume trauma, and that's tidal volume as a surrogate. We talk about barotrauma, and that's plateau pressure as a surrogate. We talk about atelectasis trauma, and that's PEEP to try to prevent that. And then there's driving pressure, and you were instrumental in pushing this concept. What is that? Could you tell us about it?
I think it has, let's say, just we need some background. I had a very good professor in histology, and he was talking all the time about alveolar simplification, which means that you never get one alveoli that gets stiff. What happens in the lung when you have a disease, especially acute diseases, is that you have few alveoli, but not stiffer alveoli. So each alveoli is still very soft with a thin septum. So, which means that when you think about the physical force that is causing injury, is the tension in the septum. So, and this is how we came to this idea that volotrauma, barotrauma, everything could be condensed in this concept of, let's say, driving pressure. But we need some caution, because when we use this term, in fact, I would like to say transpulmonary driving pressure. We just use driving pressure because it's easy at the bedside. But I think the correct term is that transpulmonary driving pressure trauma. But it gets too long, so no one is going to use it. But the concept is very important, because volotrauma is a representation of this when you have a little bit better compliance. Barotrauma when you have a lower compliance, but everything is the tension in the septum. And the important thing, I think, which is a kind of evolution of the concept, is that sustained tension does not cause injury, because the cells, they adapt. They increase the size of their membranes. They have a lot of reserve of membrane in the endoplasmatic reticulum inside the cell. And then there are very fancy studies showing that you have a storage of cholesterol in the endoplasmatic reticulum. And then when you have a big stretch of the cell, you have holes, and then you have a migration of this cholesterol to the membrane, and then they seal, they heal. Which means that a sustained stretch does not cause injury, but a cyclic stretch, this is what causes injury. So when Didier Dreyfus coined the term volotrauma, I was already concerned, because I didn't like it, because, just as an idea, how he came to this name. He came to this name because when he put a big pressure inside the lung, okay, barotrauma, he had injury. But then if he put the same pressure but with a strap, around the thorax, then he didn't have any injury, even having 40 centimeters of water of plateau pressure. And then he said, oh, in one case I have high volume, in other case low volume, so volatile. But what was happening, in fact, is that when you trapped the thorax, the transpulmonary pressure was very low. And then a sequence of further experiments made very clear that it was not the volume per se, it was the transpulmonary pressure that was causing the injury. So I think driving pressure is just let's say a simplification of the term transpulmonary driving pressure. And I think this organizes all the forces that are causing injury.
Right. If we do not talk about the transpulmonary pressure yet, but just driving pressure without transpulmonary, in your New England publication, you define it as plateau pressure minus PEEP,
Exactly.
as well as tidal volume divided by compliance.
Perfect.
Yeah, and you found that it was associated with mortality.
Yes.
What I wanted to ask you was that when we talk about plateau pressure and PEEP, we set the PEEP. We can adjust the plateau pressure using small tidal volumes, but a lot of it is also dependent on the compliance of the lungs. Yes. Similarly, when we talk about tidal volumes, we can set that, but we can't really set compliance per se. So in the end, driving pressure is, am I right to say, a mix of something you can set, but also dependent on the patient's respiratory system mechanics. And so if that is the case, is it a cause or an effect? Is it something you set and as a result, the mortality gets better? Or is it because the patient's mechanics are bad and as a result, the mortality is supposed to be bad?
Oh, this is an excellent question. And I think this was the major concern of the reviewers in the New England paper. And if it was not for the mediation analysis, they would never accept the paper. And some people is still very skeptical about mediation analysis, but mediation analysis is, I think in a few years, everyone is going to be using this because it's almost impossible to do randomized trials for everything, but it's very easy to do mediation analysis for trials that were done very observational trials that were already done, but then you can perform this kind of analysis with much less. It's not zero bias, but it's much less bias than when you use subgroup analysis, because in mediation analysis you use the whole population, so you don't have to choose certain thresholds and things that, oh, in this condition this works, in this condition this does not work. But it still is a step forward in terms of conclusions. It's not perfect as a randomized trials, but it's a good solution to understand this. Okay, let me more or less explain how it works. We did also a multivariate analysis where compliance was already adjusted. The model was already adjusted for compliance, and despite that, driving pressure appeared as another independent variable. So, which means that despite that, when you adjust a model for compliance, you can imagine as a mental model, you can say, oh, if I adjust for the effect of compliance, it works as if all the population had the same compliance. But now I have tiny variations in driving pressure, and let's see how it works. And it was exactly like this. You know, I had a bunch of patients with, let's say, 40 of compliance, and I had a bunch of patients that instead of receiving 6 mLs per kilogram, they were receiving 4, and some of them they were receiving 8. And this tiny variation was captured by the mediation analysis. And then it got very clear that those receiving higher driving pressure, they were dying more. So it means that for the same compliance, a tiny variation in driving pressure was causing difference in mortality. And the interesting thing, Jason, is that this did not happen for tidal volume. This was beautiful. I think this message in the paper was a little bit in between the lines, but if you do the same kind of analysis for tidal volume, it doesn't work. Which means that you have some flexibility of changing your tidal volume, provided that your driving pressure is low. And this is exactly what we are testing now. We are testing in some randomized trials the idea that you don't need to keep tidal volume at 6 if you have a good compliance. You have let's say you have the freedom to use a little bit higher tidal volume in order to decrease sedation, in order to decrease the side effects of keeping precisely 6 mLs per kilogram. So I think the driving pressure concepts works in both ways. Sometimes we say 4 mLs per kilogram is too much for this patient. I need 3, I need 2. And I did it a lot during this pandemic. And on the other hand, when I want to promote the weaning of the patient, the flexibility of using 7 or 8 mLs per kilogram is very useful at the bedside if your driving pressure is low.
Right. So you said you are doing a randomized controlled trial. So it's driving pressure versus the usual 6 mL per kg, or?
Yes.
Right.
And there is an innovation in this trial, which is we are going with controlling driving pressure till the weaning phase. So even if the patient is doing spontaneous breaths, we are measuring how much force the patient is doing and computing as part of the driving pressure. And how can you do it? You can do in both ways. First is that every single day we perform a compliance measurement, static compliance measurement, not using long pause, short half-second inspiratory pause and expiratory pause, and we give a shot of propofol. If you feel that this is not enough, we give a succinylcholine, which is a very fast paralytic agent, and then 5 minutes later, the patient is doing normally. So we have this compliance measurement every day, and then along the day, we control the tidal volume because we divide tidal volume by compliance, and then we know how much driving pressure the patient is doing every cycle. This is one approach. If the patient is too close to the weaning, and then we don't want to give this paralysis, which is very safe. I have performed thousands of these, but if the patient is too close to the weaning phase, then we use the technique described by Ewan Gallagher. We promote the expiratory pause. Bertoni and Gallagher. We do the expiratory pause and we measure the occlusion pressure, how much force the patient performs during an expiratory pause. And then we take 75% of this as the muscle driving pressure, let's say. And then we add to the inspiratory pressure that you are using in your ventilator, the static inspiratory pressure that you are using in your ventilator. So then I try to keep the total driving pressure below 15 and ideally below 12.
Interesting. So uh, you measure the occlusion pressure as defined by Ivan Gallagher, and that's the patient's own diaphragm.
Yes.
And then you take 75% of that, you add
Yes.
and you add the
The delta pressure that we are using in the ventilator, for instance, if I using 5 of pressure support, I compute more 5. But
right.
there is a an important caveat. Especially in COVID, my pressure support, the cycling off is at 1%. I use very low
Wow.
cycling off.
Okay.
Yeah.
Okay.
So then when I have the plateau or peak of pressure support, I don't have a resistive pressures
Right.
working because the flow is very low. So I can say that, okay, this airway pressure, the delta pressure is almost a static pressure.
I see. I got it. Right. Oh, interesting. So because personally, I've always struggled it, uh, 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 about how to actually adjust the driving pressure, because one way is to think about it is plateau pressure minus PEEP, which means that I either reduce the plateau pressure or I increase the PEEP or both. And the other way is tidal volume and compliance, as you said, which means depending on the compliance, I can set the tidal volume. So what is your preferred method? Is it a tidal volume thing or is it a PEEP thing? Yeah.
I prefer the tidal volume because oh no, there are two. Let's talk about measurement and controlling.
Yes.
Okay. Yeah. Measurement. I feel much more. Let's say I feel that I have more precision when I measure compliance once a day.
Right.
Because we know that these occlusion pressures, you have to do lots of averaging because it varies a little bit from cycle to cycle. So when I measure compliance, I feel that I have more precision in the measure. Anyway, but if the patient is very close to the weaning, you cannot, let's say, paralyze the patient in that moment. So, okay. But to control driving pressure is very tricky. And this is something that I learned a lot during this COVID pandemic, because we have to understand very well how the respiratory drive works, because it's can be a big mess. And then I like to, for instance, I like at first to define, is this patient having an appropriate or inappropriate respiratory drive? And what I call appropriate is a respiratory drive that is following PCO2 and pH, and also the mechanical. If you give more support, the patient relaxes. If you give less support, the patient works more, trying to keep, let's say, an adjusted pH and PCO2. So this is appropriate and have been described a lot in the literature, the response to pressure support. But I would say that more than half of the patients during the acute phase of COVID, they have inappropriate respiratory drive. So they do not respond to changes in pressure support. They keep doing a very high and strong force to breathe. And also, even if they are alkalotic and with low PCO2, they keep working very hard. So I like to define these two extremes because then the treatment is completely different. For instance, if I have an appropriate drive, the first thing that I try to do is to decrease pressure support. And then I decrease, and I have had lots of patients under CPAP, because then the only force, the only driving pressure is the muscle driving pressure. And then I'm not adding anything else. And I think it got, let's say, implanted in our brains that we cannot use less than 5 of pressure support. But this is for COPD. This is for patients with muscle fatigue, but not for a healthy patient that got, let's say, got COVID. And these patients, they have a lot of force. It has been my experience. And then they can breathe under CPAP very easily. And then I give appropriate level of PEEP. The patient is under CPAP, and then I can control the driving pressure because his muscle pressure is 12 or 14 or 15. Okay. But then when we go to patients with inappropriate drive, then you have to use some tricks. So sequentially, I try to do 40 steps. I try to first to promote a little bit more alkalosis. I try to give a little bit higher oxygen because some patients, the response to hypoxia is very weak, but some patients, they have a big change in the respiratory drive when PO2 is below 80. So from 60 to 80, you still have some inhibition of your respiratory drive. And some patients, they have a dramatic response when I increase my PO2 from 60 to 8. And then, for instance, I had patients in which the minute ventilation decreased by half just by doing this. So it was mind-boggling for me. I was not expecting this. Okay, so pH first. Second, the control of a little bit higher PO2. You have to test in every patient because it does not work for everyone. Then, if it does not work, I try to increase a little bit the PEEP, not because of driving pressure, not because of hypoxemia, but testing if this patient has some inhibition of the drive by increasing PEEP. And this is something that we studied a lot in the last years. We studied in animals and then in humans, trying to understand the let's say, the inhibition of the ventilatory drive by PEEP using the Herring-Breuer effect, reflex. So, and some patients, they have a very nice response. They decrease the drive and the frequency. But some patients, they started to have stronger efforts, very likely because they increase the PCO2 or increase too much the dead space. But you have to test, but changing a little bit the PEEP can be helpful. Okay, once I have done the 3 attempts, then I have to give sedation. And then I think the best sedation by far is propofol. Propofol is the best agent because propofol is the only one that consistently decreases the frequency and the strength. For instance, if you give opioids, typically you decrease the frequency, but not the strength. And so we have used a lot of propofol for doing this kind of control. And then the last resource is to give a little bit of partial paralysis. I have used a lot of partial paralysis because what is beautiful about partial paralysis is that you are not changing the respiratory rate. You're just decreasing the strength. And I think the respiratory rate is one of the best indicators of the consciousness of the patient. So if your patient has a very low respiratory rate, you can be sure that he's not feeling the partial paralysis. So this is how I try to control the driving pressure during all the stay in the ICU.
Right. Thanks, Prof. You were talking about transpulmonary pressure right at the start. You also said that you try to keep your driving pressure below 15, preferably below 12. But when you
Yes.
do these calculations, do you think you are measuring transpulmonary driving pressure or just
No,
driving pressure?
no, just driving pressure.
Just driving pressure. Yeah.
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 I there is something that I never had time to explain. I have measured esophageal pressure in
Mm.
tons of patients, and in my observation, a change in the chest wall compliance is very rare. I think I have seen that obese patients, they have exactly the same chest wall compliance, thin patients. So a change in chest wall compliance is very rare. And typically when you have it, it's very easy to understand because typically I have seen only in two conditions. So let's say a clinically important change in chest wall compliance. When the patient has chest wall deformation, like scoliosis, and when the patient has abdominal hypertension. Except for these two situations, it's very rare. And then in a typical patient with ARDS, you are spending 2 centimeters of water of driving pressure on the chest wall. The rest goes to the lung. And so more or less, when the patient has 15 of driving pressure, you have 2 centimeters for the chest wall and 13 for the lung. And more or less is, I think this is more or less the safe threshold according to some experimental studies.
Right. Got it. So in most patients, even if you don't measure transpulmonary driving pressure, it's fine. Yeah.
Yes.
Right.
So
yeah. I wanted to also touch on the concept of mechanical power. The power of the ventilator on the lungs, and I mean, we've seen the formulas is tidal volume, respiratory rate, all kinds of pressures, peak pressure, plateau pressure, PEEP, driving pressure, etc. And buried within that is driving pressure. Could you share more? What do you think is more important?
Absolutely. No, absolutely. Because I think this concept is beautiful, but I think there has been lots of misunderstanding. First, because you have to think that even if, let's say, the lung is a kind of old thermodynamic machine, like, let's say, a vapor machine. So in thermodynamics, mechanical power is all the energy that is transferred from the ventilator to the lung. But you have to think that if the lung was a perfect elastic body, there is no dissipation of energy, so there is no injury. Physically, it's impossible. So even if this formula is correct in terms of transfer, in terms of thermodynamics, what must cause injury is the dissipation, is the energy that is not given back when you have the exhalation. So then even the mechanical power is not the proper measurement to understand injury. We should be measuring the dissipation of this energy that is transferred. And some people working with Gattinoni, like Proti, they tried to measure this dissipated energy. And it's very difficult to measure because you have to measure the hysteresis area, and the signal to noise ratio is very low. And then it's very difficult to measure at the bedside. Okay, so this is one point. The second point is that in terms of thermodynamics, computing the resistive work or the resistive power does not make any sense, because it's also something that is completely dissipated in the endotracheal tube and airways, and it's not causing injury. And we have a very good example how the energy dissipated in the airways should not be computed, because we have this experience with asthma patients. And then you can dissipate a lot of energy in the airways and you don't get VILI, you don't get ventilator-induced lung injury. So dissipation of energy in the airways should be out of the formula. And finally, I think there is this dilemma if PEEP should be in the formula. Because again, from the physical perspective, PEEP is a potential energy that is stored. Because you can imagine that, okay, let's suppose that the patient has a disconnection of the ventilator and now is completely relaxed. If you are going to put the patient under mechanical ventilation again, you connect the circuit, the PEEP is going to be set, and it's just going to be one inflation. And later on, you are going to be on the plateau pressure and back to PEEP, plateau pressure and PEEP. So this energy transferred by PEEP was just one. So, and then from a thermodynamic perspective, this is potential energy that is there and should not be related to injury. So this is my concerns from a physical perspective. Now, I think the concept is beautiful enough, and then we decided to analyze this concept. We published a recent paper in the Blue Journal, where we are checking every power component and checking if they have a relationship with mortality, each one independently, and then all of them combined. And then what we realized is that driving pressure is a very important, it's the most powerful of the parameters isolatedly. Then we have respiratory rate, and then nothing else. So tidal volume does not, PEEP does not, and resistive pressures does not. So this fit, in my mind, this is very beautiful because it's more or less what we should expect. So driving pressure is extremely important, and a little bit of respiratory rate, and the ratio is 4:1, which means that for each centimeter of water of driving pressure that you can reduce, let's say you can, this could be counterbalanced by an increase of 4 breaths per minute. So, and I like this ratio because it's very helpful at the bedside. For instance, if you are in hypercapnia, you want to reduce driving pressure, but to do this, you have to increase, let's suppose you decrease driving pressure by 1, but then you have to increase your respiratory rate by 4 breaths per minute. So your total result is null. So it's not protection. So I like this. And because then you can take decisions. For instance, now, every time I try to reduce driving pressure, I try to increase hypercapnia, but I don't increase respiratory rate. So I try to control a little bit better hypercapnia by decreasing that space, by decreasing the glucose amount that I'm giving to the patient, decreasing temperature, but I do not increase the respiratory rate. I think this was a very important concept.
Right. Do you increase the respiratory rate, say by 2, and then you drop the driving pressure by 1, and so the net effect is better?
Sometimes, certainly yes. Yes,
right.
Certainly yes. Yeah.
Right.
Yes, precisely. And also, what is beautiful about this, Jason, is that it's possible to calculate for each patient the ideal respiratory rate. So, because if in the paper of the Blue Journal, we can show that there is a U-shaped curve for each patient in terms of respiratory rate. Right. So each patient has an ideal point of respiratory rate. And then if you try to use more or less, it's counterproductive, because you have either to increase too much the driving pressure, or you have to increase too much the respiratory rate, with some increase in dead space that is going to make it worthless. So each patient has an optimal respiratory rate, and to compute this, I would need to measure just two things. I just need the compliance of the patient and the dead space. Having these two terms, I can calculate the ideal respiratory rate for each patient. I believe that this is the future.
Great. Yeah, thank you very much, Prof. We've discussed a lot. Maybe just some last words, final advice to anyone listening out there, how you want to summarize how you use driving pressure, or anything that we haven't discussed at all. Yeah.
Okay. I along the time, I have had more and more evidence that this concept has been very useful in many different trials, in ARDS, in extracorporeal circulation, in every field, in neonates, in children. I think the driving pressure has been the strongest single variable related to mortality and billing. And so I'm getting more and more confident that this concept is very useful at the bedside. I think the addition of respiratory rate was also an important contribution. And I think using this concept, we in the recent years, this has been very helpful to adjust a little bit better the tidal volume of patients, because this concept that 6 mL per kilogram is good for everyone can't be true. From every angle you look at, it's absolutely obvious that in some patients you have to use much less, and in some patients you can use a little bit more, because you have a safe driving pressure. And just to give you an example, this is why we have marathon runners using 3 liters of tidal volume, because they have a very good compliance and they can work at a very low driving pressure. So I think this concept is going to help us to avoid many dysynchronies that we see under mechanical ventilation. And for me, it's no wonder that some trials trying to control tidal volume at 6 for patients with very good compliance have not worked, because you have some side effects of trying to keep a very low tidal volume in a patient that has a good compliance. So this is my final message. And thanks a lot, Jason.
Thank you very much, Professor Amato. And to all listeners out there, I hope this was useful in your daily clinical practice. This has been the AVF podcast. If you liked it, please feel free to share it with your colleagues. Hit the like button, subscribe, follow, whatever. This is available currently on YouTube as well as Spotify. Till the next time, thank you. And thanks again, Prof.
Bye.
Bye.
My pleasure, Joseph.